So I wanted to start this evening by just sharing a little bit of my story and also the story of some of my patients. And if I start my story back in 2011, I was pregnant with my fourth child, and I went to an obstetrician appointment at about 34 weeks. And the obstetrician kept frowning at the ultrasound screen, but I could see the baby looked fine and he was really active and his heart was fine, but I saw this very concerned look on my obstetrician's face. And he told me there was something on the scan that he didn't really like the look of. And to put into context, 18 months prior, I'd had an abnormal mammogram, diagnosed with the BRCA1 mutation, which is a breast and ovarian cancer gene, that I watched my auntie die from, and two of my cousins have breast cancer in their 20s and subsequently die. And so it was a very confronting time, and here I am hearing that actually there's something that doesn't look quite right. And so he tells me, look, I think when we go to do this next cesarean, we really need to think about removing your ovaries. 2 days later, I don't know whether it was the stress, at 34.5 weeks, I went into labor, and I'd had previous cesareans, so I found myself in the operating room, going from the heady heights of pregnancy hormones up here, and within 45 minutes, I was menopausal. Now, at that time, and I will stress that things had changed a lot, it was thought that anyone who'd had any type of cancer or anyone who had a high genetic risk should never have hormone replacement therapy. So I was pretty much told to do my best, and if the hot flushes got too bad, to let them know, and that maybe they could put me on a small dose of hormones. Now, I'm not really usually such a literal person, but for some reason that just stuck in my head. And to this day, I've actually never had a hot flash. And so I went along my merry way and had symptom after symptom. But the problem with menopausal and perimenopausal symptoms is they're often so easy to attribute to other things. So I could not sleep. I literally, no matter how tired I was, I could not go to sleep. It didn't matter if I was worrying about something or not worrying about something. I could just lie there with an empty mind, but I literally could not go to sleep for more than 2 to 3 hours per night. But it was easy to put that down to 4 children, babies, a child that was unwell, so that was easy to dismiss as other reasons. And then I started to get really sore joints in my hands. And to be honest, I felt guilty because I thought, oh, maybe I was looking at my phone too much, and maybe that's what was causing my hands to be sore. And as you all know, I'm a GP. And then it started in the GP rooms, and I've got some of my nurses here. And I'd have to excuse myself from the patient, and I would go into the treatment room, making an excuse that there was a patient in there that needed me, but really I was whispering to the nurse, can you remind me what you call the name of the drops we use for swimmer's ear? Or can you remind me of the antibiotic that we tend to use for? I'm pretty sure it begins with M. And so then I began to think, I've got dementia. This is like really bad. I've got dementia. And the thing that was also really annoying was that in all my other pregnancies, I'd always managed to get back to a reasonably close to my original weight. But this pregnancy seemed to be different. I just seemed to be getting bigger and bigger, and my belly seemed to be getting bigger and bigger. And I thought, okay, well, there is a difference because I couldn't breastfeed this time, so maybe that's what it was. And so I went along for a really, really long time, just not really being able to understand what on earth was wrong with me. And that's clearly ridiculous, because obviously I'm a doctor, and I should know better. But for a very, very long time, I was a really, really bad menopause doctor, and I'm really trying to change that now. Now, the reason I want to share my story is because taking hormones has really been transformative for me, and it's really changed my symptoms. Within 2 nights, I suddenly went to sleep every night. It was so exciting. I used to dread going to bed. I absolutely dreaded it. I dreaded if my friends asked me to go away for a girls' weekend, because I knew I'd be up walking around the apartment or house, wherever we were. And literally, it was an overnight success. And I think one of the other things that's always hard to talk about is that I actually had a lot of vaginal and urinary symptoms. And of course, no one really wants to talk about that. But they're awful, and they massively impact your life. And yet you can actually take hormones, and the next thing, over a short period of time, it's really quite transformative. So I'd love to start tonight by asking you to share your story with someone, and we're all going to have a unique experience. Some people will sail through the perimenopause, and other people, it is an utter nightmare. But we know from research from the UK, which has been published quite recently, that a very, very high proportion of women have at least 14 symptoms. So this is not just a couple of things, no periods, and a couple of hot flushes, and you'll be right. It's just not like that. And I know some of you already know some of this information, but just to let you just put it all into your head, because there's even doctors who get this mixed up. So menopause is one day, 12 months after your last period. But how does that work for someone like me? Because I had my ovaries removed, other people have their uteruses removed, some people have a marina, so they're not having periods. So it's not the best diagnosis that we've got, but it's what we've got. The post-menopause is every day for the rest of your life after that one day. So people ask me all the time when it's going to end, but the reality is it's not. But the good news is that we're going to tell you how to absolutely thrive at this time. And so what many of you don't know is that, whenever you're in your mum's uterus, whenever she was 20 weeks pregnant with you, that was the maximum number of eggs that you had in your ovaries. And then it's on a downward slope. And really what the menopause is that your body has completely used up all your eggs. And the perimenopause is when the ovaries are coming to a stuttering stop. So these are the graphs that we see, and it tells us that whenever you're in the premenopause, which is another definition, but you've got these nice hormone levels going up and down in this sort of like really smooth pattern. I mean, obviously it's not like that for everyone. So that's what I think the perimenopause looks like. It's absolute chaos. You can do your hormones on a Monday, and they'll be the highest they've ever been, and you could do them on a Tuesday afternoon, and they could be in your boots. And therefore, that is why it's actually really, really challenging to have a blood test or anything that's going to be helpful in this situation. And then, of course, we have all the symptoms, and people will say to me, well, is it really going to cause that many symptoms? That sounds a bit dramatic and over the top. But what we now know is that we have for too long been thinking of these hormones that really reduce at this time of life as sex hormones, or about babies, or about pregnancy, or about puberty. But actually we've put them in a box that they never belonged in. And actually their whole body hormones are messengers. And we know that because whenever we look at any type of cell really in our body, you'll pretty much find receptors for those hormones. And a receptor, I think of a receptor as being a little bit like a little garage that only takes a specific type of car. So you've got a garage for your estrogen, and a garage for your progesterone, and a garage for your testosterone, and a garage for your dopamine. And if the cell didn't need it, then it wouldn't have a garage for it. And what we know is that everything from your brain to your kidneys to your blood vessels to your bones to your muscles, every place you can really think of needs these hormones. So everyone always thinks of hot flushes, but I have to say when my patients come to see me, hot flushes are definitely not the top of the list. I would say that sleep disturbance is probably the main one that people complain of, anxiety and irritability, and also weight gain. And all of the above. But basically you can start at the top of your head and work your way down from thinning hair, itchy ears, tinnitus, vertigo, dry eyes, burning tongue, reflux, change in bowel habits, and you go on and on and on. Frozen shoulders, hip pain, muscle aches, plantar fasciitis, pain in the joints, and then, of course, the all-important growing symptoms. So I see women who have had really top jobs who no longer can run a meeting because they can't remember what they're trying to talk about. Or we have women who just have had such an utter loss of confidence. I've also had women who've worked in the same place for 20 plus years, and suddenly they're getting complained about because they're irritable and angry. A lot of women will come into me and they just say, I just feel really annoyed by everyone. I feel annoyed by their chewing, I feel annoyed by their breathing, and actually may murder my partner. So absolutely, we cannot diagnose the perimenopause with a blood test. Now, if you come to see me, I will send you for blood tests, but that's not because I'm using that to diagnose your perimenopause. I want to check out and make sure that you're not iron deficient or vitamin D deficient, or that you haven't got insulin resistance, or your cholesterol's not high, or your glucose isn't running high. So lots of things that we see abnormal. So you will have lots of blood tests with me, but I will not say, oh, your hormones are normal, so it can't be the perimenopause. And if anyone tells you that, to be honest, you need to go and find another doctor, because that's not correct. Perimenopause is a diagnosis made on your history and what you tell me. And the reality is that you know your body, and I believe you. When you come to my clinic, I will give you a number of questionnaires to fill in, and we will ask you every possible question that we can think of to really discern what is exactly going on. But I will not hang my diagnosis on a blood test or not. Now, the post-menopause is a little bit different, because that is something that we can see on a blood test. Now, for years, hormone replacement therapy went out of fashion, and we're thinking of HRT, or sometimes it's called MHT now. We're thinking about estrogen, progesterone, and testosterone. And for years and years, it kind of went out of vogue, and we sort of stopped talking about all of this. And I don't believe for one moment that women's symptoms were suspended somehow in animation, but you probably all know the reasoning. There was a big study in 2002, they held a press conference, and they seemed to imply that hormones seemed really risky to take, and that they were a very worrying thing to take because they caused a really dramatic increase in breast cancer. Now, that could be a whole talk all by itself, but suffice to say that multiple of the investigators from that study have walked away from it, and also realized that they had perhaps misinterpreted data. And in fact, even within an arm of that original study, they actually had another arm that had a 30% reduction in breast cancer from taking estrogen. So I think all of us, particularly us doctors, have learned a really important lesson, that we probably needed to be a lot more inquiring. I was a very, very junior doctor in Belfast when this all came out, and we were very strongly told that we had to phone all these women and stop their hormones. And I do look back and I think, what a great disservice we did to so many people. And I wonder how many lives were lost through hip fractures and heart disease and sepsis from urinary tract infections. And in reality, we probably really over-exaggerated the concerns. Whenever I talk about HRT, I'm talking about prescribing you what I call body-identical hormones. And that's not something that we have compounded. It is something that you can go to the pharmacy and comes in a pack from a pharmacy or from a pharmacological company. I use an estrogen or estradiol that I put through your skin. Now, I would like to do it with a patch, but we don't have any. So at the minute, we're using gel all the time. And if that's great too, because the reality is you can change the dose really easily by just changing the number of pumps. If you've got a uterus, you do need to have progesterone. And that's because if I just give you estrogen, which does cause probably a very significant proportion of the symptoms, but if I just give you estrogen and you still have a uterus, or you don't have something like a Mirena, the risk is that you're going to end up with a thickened lining. And the risk of that is that that will increase your risk of getting endometrial cancer. Now, I will point out that the vast majority of people who get endometrial cancer are not on hormones, but it is something that we think about. Progesterone also has added benefits. I know I've got lots of my patients here tonight, and lots of them love their progesterone because it often helps you sleep. There's definitely lots of research ongoing, and again, there's progesterone receptors or little garages for progesterone in a lot of cells, in our brain, in our bones, muscle, etc. So I think, as time goes on, we're going to learn more and more about these hormones. I just want to mention one thing. If there's anyone in the audience who is postmenopausal and not on hormones and has a partner of roughly the same age, a male partner, I should point out, your male partner will have more estrogen in their body than you will. And so we have to get away from thinking about these hormones as being male and female or pink and blue hormones, because your testosterone is really important for your well-being, and also the estrogen is important for your partners as well. So I think we have to really debunk a lot of myths. So the first one is, you cannot have HRT if a family member, no matter how distant, had breast cancer. That is definitely a myth. In Australia right now, 1 in 7 women will get breast cancer. So if you think about your family, can you think of 7 people in your family who are female? Aunties, grannies, second cousin, whatever. Very quickly, everyone's going to get to 7, 14, 21, 28. So pretty much everyone's going to probably have someone in their family with breast cancer. So someone else's breast cancer is actually not a contraindication to you having hormones. Another myth is you can't have HRT if you have fibroids. That's not true. Another one is you cannot have HRT if your family has a history of blood tox. As I mentioned, I'm putting your estrogen through your skin, and we know that transdermal estrogen does not have an increased risk of clots. Another myth is that the risks of HRT outweigh the benefits. We absolutely know that is not true. In fact, it's the absolute opposite for the vast majority of women who want to take HRT. Some people don't want to take it, and that's absolutely 100% fine. But if you do want to take it, I think you're entitled to have the conversation and also know that the risks for most people outweigh the benefits. We've already touched on HRT causes breast cancer. I get that written all the time on Instagram posts and things, and it's just simply not true. Another myth is that HRT is only for hot flashes or hot flushes. Again, it works fantastically for hot flushes, but is definitely not the only reason to use it. There's other myths that you have to stop after 5 years. Definitely not true. Another myth is that you don't need HRT if you eat well and exercise. You cannot out-exercise your lack of estrogen. However, I do want you to eat well, and I do want you to exercise, and we are going to talk a lot about that. Dr. Vaughan is going to talk a lot about that later. So it's not that I don't want you to do that. We know you need to change how you eat for a lot of you, but that is not going to be enough. The other one is natural remedies are just as good as HRT. What can be more natural than me giving you a hormone that your body recognizes as itself and can metabolize? It's even got a little garage for it to go and hang out in. What could be more natural than that? That's more natural than me giving you an antidepressant. So I think we have to really think about what we mean by the word natural. Another one I hear all the time is HRT will make you gain weight. Well, that's actually not true for a couple of reasons. But one, if I put you on HRT and you suddenly get some sleep, your cortisol levels are going to go down and you're going to be less likely to make bad food choices. You're going to be less likely to crave carbohydrates and processed foods. And you're probably going to have a lot more energy to actually get out and do exercise and enjoy yourself. So we know that that one's not true. I just want to finish by talking a little bit about what I see in my clinics. And lots of times people ask me, well, what kind of clinic do you have? And sometimes I really struggle to say what kind of clinic I have, because I help people with perimenopause and menopause, and I help people with their weight, and I help people with their skin. But really what I hope I do is that I help people with their confidence. Because I see so many women who come to see me who no longer have any confidence in their brain to function, to remember a word, or to be able to go and socialize and feel like they're enjoying themselves, or be able to drive their car to Sydney and not be freaking out with anxiety. I hope I give them their confidence back in their skin, because often people get rosacea and acne, or worsening eczema, or dry skin, or skin barrier that's completely impaired. And I hope that I give people confidence back in their bodies to function like they're supposed to, for them to be able to get rid of the joint pain that's stopping them exercise, or get rid of the hip pain that's stopping them lying on their side in bed at night, or get rid of the vaginal dryness that's causing them to be unable to have sex with their partner. So basically what I'm trying to do with Everything at You by Dr. Shauna Watts is that you're going to arrive with me as you, and you're going to leave as a more confident you. But I'm definitely not trying to change you. That's not what I want to do at all.
So you've seen many of your favourite doctors wearing weighted vests when they're out walking, and a few of you reached out to ask me, why are they beneficial? Well, look, there are lots of benefits, but one of the main ones that's a real focus for us who are interested in that menopausal space is the improvement that they cause in your bone density. So as we age, we actually resorb more bone than we make, and the bones unfortunately do become weaker. And for some women, that progresses right onto the stage of osteoporosis and then fractures. So wearing a weighted vest increases the weight that your bones and muscles are having to carry, and that encourages the cells called the osteoclasts to make more bone. Now, there are lots of other benefits of weighted vests, including strength, core stability, and also probably reducing your risk of falls by improving that general overall stability and strength in the lower limbs. We love a make called Ruck Vest, and I've been able to negotiate for my listeners a bit of a discount. So if you go to www.rucksack.com, Ruck, R-U-K, Sack, S-A-K.com, and use the code Shauna15, that's S-H-A-U-N-A 15, you'll get a 15% discount off your Ruck Vest. I hope that helps you all. I'm really excited to see you out wearing your vest. This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.